Hi everybody, we're back with our last chapter from our research book. So this is chapter 13, Building an Evidence-Based Nursing Practice, which is really why you're here. This is what you're learning how to do in your general daily practices. So evidence-based practice, practice is founded on research. If we don't base our practice on research, we are not building the best practice that we can. So research means nothing if those practices are not adopted into practice, though. So we can do all the research we want to, but unless we have actually put those practices into place, we're still not doing the best thing for our patients. So some of the benefits there include improved outcomes. Gold standards. So we get gold standards, like the American Heart Association has some gold standards for cardiac care and for stroke care. So the way that they've determined those is that they've done a lot of research and they've done some analysis, which we'll talk about here in a little bit. And they've decided that the best evidence that they have indicates that these are the things we should be doing. And so hospitals are held to those gold standards when they're providing care to those patients. It revises our standards of care. So there's things that we do all the time throughout the facility that we change how a protocol is done or how a process takes place, and that's based off of evidence-based practice. Of course, quality improvements are important, and then magnet status, which is not something that we have at St. Elizabeth's Hospital, but it is something that some of the hospitals in our area cooperate with or take part in. And it's a process basically that holds that hospital to a higher standard. And it's really based on the employee side of that standard, not just the patient care side. So what are some challenges? We don't have evidence as often as we need it in nursing practice. There's a ton of evidence out there on the physician side of things and medicine in general, but for actual nursing practices, there's really not much scientific research done. It's expensive. Typically the people doing the research are doctors who are doing research into doctor type care. So it's difficult to get true high quality nursing research articles, which is where you guys are involved. We need to start expanding that net and making sure that our nurses are capable of performing high quality research. Evidence is based on populations and not individuals. We all know that generalized populations do better with certain types of care, but there's an individual out there that doesn't do as well as everybody else, or we try one thing with them and it works fantastically, but it doesn't work for everybody else. So patients are individual people. We have to treat them as such. So it's difficult to say what a best practice truly is when everybody's a little bit different. Lack of support or money is really a problem. I think we tend to really promote evidence-based practice. We do poster projects, we do things on the unit practice councils to try to change and to improve best practices. But those things do cost time and they cost money. So without having access to both, you're not likely to be successful. Of course, heavy workloads play a part. So nurses that are burned out after working their 312s are not likely to go back and do research on their fourth day. And we still have to pay them for that fourth day. So having heavy workloads is a challenge. And then, of course, minimal rewards. What's the reason I want to do this evidence-based practice? Because it's a headache. It's a headache to put it together. It's a headache to put it into place. And it's exhausting to try to maintain it. So, what's the point? What's the purpose here? So when we're talking about developing research, one of the easiest ways is to use the PICO format, and that's to present your clinical questions. So P stands for population, I is for intervention, C is comparison of interventions, and then C is your outcome. So for an example, this is should nurses aspirate when giving IM injections? According to our population is going to be adults receiving immunization by IM route. The intervention is IM without aspiration because that's our changed intervention. Comparison is IM with aspiration because that's the standard of practice currently. And then the outcome is injection of the vaccine without complications. Now, you'd have to have a huge number of people for this project to be worthwhile. Why? Because standard of care, best practice, says that we aspirate afterwards. But how many patients in the years and years and years that you've been practicing have you had any poor outcomes, whether you've aspirated or not? It's been a while, right? So you're going to need a huge number of people to make this study successful, but it is an example of what that PICO format looks like. So systematic reviews are a structured, comprehensive synthesis of research literature to determine the best evidence available. This is considered the gold standard of research. If somebody has done a systematic review of the literature, we have a comprehensive guide to what the literature actually says is best practice. So the goal here is to identify that literature, they'll appraise it, synthesize the results, and that's usually conducted by 2 or more researchers. That's to make sure there's no bias in the results, and it follows a checklist. That full checklist is actually on page 395 of your book if you'd like to see it, but these are things that you should already be doing anytime you look at research. What was the scope? How did it come up in your search? What's the title? What were the inclusion and exclusion criteria? Was it selective enough? Was the data valid? What was the structure? How reliable is it? Was there bias? Those are all really important pieces of any kind of research, but when doing a systematic review, they perform it at the highest level. Another really high quality study is a meta-analysis. So as you're doing your research, if you come across a meta-analysis of anything or a systematic review, those are the ones that you really want to look towards for your gold standard advice. So meta-analyses, or analyses, are conducted to pool or combine results from previous studies into a single study. The goal is to find the highest level of evidence for the effectiveness of an intervention, and studies have to be similar or else there's going to be bias, and it creates a larger sample size to statistically analyze. So again, if your sample size, for example, on a face wiping product I recently encountered, they said that 95% of women saw a reduction in fine lines around their eyes. And when you look at the fine print, 95% of women did see a reduction, but there were only 18 women in the study. That's not a high enough sample or a large enough sample to have a quality result. So the meta-analysis allows you to take other studies and combine them together so that you get a better sample of what's really happening. So you can see here all reviews of literature here. Systematic reviews have very specific criteria, and then your meta-analysis is kind of in here where we've taken that criteria, we've very specifically put it together, and now we're looking at the generalizable results from that material. We also can perform mixed methods systematic reviews, and that synthesizes reviews from both quantitative and qualitative reviews. So that's where things get tricky, right? Because quantitative usually involves numbers, and qualitative usually involves feelings or emotions in whatever it is that you're studying. So this is a multi-level synthesis, and it synthesizes reviews of quantitative separately for qualitative, or there's a parallel synthesis, and that's findings from qualitative studies are used to interpret quantitative studies. So just to see it a little bit more visually over here, we have a research question, we do the study selection and data analysis for both types, we perform a quantitative synthesis, and then we also perform a quantitative synthesis. And just the order in which those take place is the difference between the multi-level and the parallel synthesis. So how do you promote evidence-based practice? Some of you are managers, some of you are team leaders, all of you are considered leaders in healthcare because we don't have a lot of nurses that go back to school. So this is something you're going to be looked for or looked toward to help accomplish. So we have something called the Stettler model of research utilization. So phase 1 is preparation. What's the purpose? Why are you even doing this? Is it something that actually matters to your unit? What's the potential outcomes? And then conduct a detailed literature search. You guys are kind of doing this on your project right now. Most of your projects are something that if we find evidence-based practice in those, you could take that to your unit manager or to the CNO and you could say, you know what, I found a best practice that we're not doing. Can we implement this in our practice now? Go. Sorry, Ladybug wants to be in my lecture. Phase 2, validations. So determine if your studies are valid. Watch for inadequate research. That's going to derail every single project you do if you're not finding high quality research articles. And then look for systematic reviews and meta-analysis. Like I've stated earlier, those are the ones that you really want to catch in your research studies. Phase 3 is comparative evaluations and decision making. So we kind of substantiate the evidence, fit the evidence within the healthcare setting. Does what a big hospital in New York match what we can do at a smaller rural hospital? Those things are not always the same and the resources aren't always there. So we have to look to see how likely it is that we would be able to implement the same changes. Feasibility of research findings. Again, if you need a multi-million-dollar lab to make something change, that's not likely to happen. So how feasible is it for this institution? And then concerns with current practice. How badly do we need this change? Are our outcomes good already, or can they be improved? So this is all ways that we would decide whether or not a true research study or change in practice based off of a research study is usable. So phase 4 is actually translation and application. So we plan for using research in practice. It could be cognitive, which changes how the nurse approaches things. So maybe you're talking about bedside shift report. That was a huge project that was actually based off of a doctorate project from a few years ago. And the goal there was to change the nurse's practice. It could be instrumental change, which is a support in practice or protocol or policy. And then you want to implement the project. And then, of course, stage 5 is evaluation, and that's to determine the impact the change had. No research implementation is complete without evaluation. So no matter what you do, no matter what changes you make, you have to go back and evaluate. And that's whether you're doing a formal research study or if you're just trying to change practices on your unit. If you don't come back around and evaluate how effective those changes were, you're missing the opportunity to help yourself out both in that concept and in concepts in the future. We also sometimes can use, and let me get myself out of the way, ladybug, go. We also use the Iowa model of evidence-based practice, and that's where topics are identified and then evaluated and then prioritized. So we determine what research is ready to be used in clinical practice. This is big studies. These are studies that have been done multiple times. There are systematic reviews available. There is meta-analysis available. And then what are the most effective strategies for implementing those changes? Within your research, this is something that you should be looking at in your articles. Did they say what they learned about the implementation? Because most implementations are not super smooth. There are problems that arise. There are things the researchers didn't anticipate. There's issues with nursing staff choosing to do other things when they've been taught how to do new things. So the research articles that you're going through should provide you some explanation as to how that went and what barriers they encountered. And then, of course, does the initial data support the need for change? Again, if your practices are already creating great patient outcomes, do we need to change them? And then is it a priority? Again, if 3 patients come into your hospital a year who have a certain disease process, do we need to implement a change process for those patients? Maybe not. There may not be enough of them to make it a practice change worthwhile. So it just depends on the priority, the topic, and then the research, and then what kind of outcomes we're looking at. And you can see the larger model here as to how they break that down. So evidence-based guidelines are developed by research and expert panels. So for example, the Agency for Healthcare Research and Quality is a big one. American Heart Association comes up with a certain amount of guidelines, and the American Medical Association. So the Grove model for implementing evidence-based guidelines in practice is who authored it? How high of a quality of evidence do you have? If the American Heart Association put something out, you know it was well researched, it is well delineated, and it's taken as fact by the medical community. If Joe Schmo working on his DNP project 3 years ago put something out, that's a lower quality of research. They don't have what that major corporation has, and they don't have the access to the experts that the research panel has to determine the best practices. So what's the significance of the healthcare problem? Again, if it's not significant, we're not going to spend time and effort changing it. What's the strength of research evidence? Actually, if you look through the American Heart Association stroke or cardiac guidelines, they break that down in a color format. And green is the highest standard. Yellow is this is research that we're seeing, but we can't prove it. And red is we don't have enough to talk about it, or we haven't definitively proven that this is true. And they will rank every single one of the statements they make based on that coloring system. So every provider who looks at the American Heart Association guidelines is fully aware of how much evidence backs up the research that they're using. It will link to national standards and the cost effectiveness, and then implementation into practice. So by looking at those things, we can kind of determine what's going to work and what's not. So all of these things are really important when we put practice or research into practice. So as you're doing that, or as you're thinking about your projects, try to think about what would benefit you or your unit and how likely it is that we could make those changes. As always, if you have any questions, let me know.